Hi, everyone. So I'm Mallika Mathur. I'm a postdoc fellow with a joint position with McGovern Medical School and School of Public Health. But this project was really built out of the Population Pediatric Health Initiative that Dr. Sandy McKay spoke about earlier in the day. So this quick lightning talk will be about our expansion of our social determinants of health screening and referral program into multiple community-based pediatric clinics at UT Physician. So I don't think I need to go into too much detail on what SDOHs are for this group, but we're still I'm mentally still pivoting over to NMDOH as opposed to SDOH. But back when the Population Pediatric Health Initiative started coming together, one of the priority needs was to start screening and addressing SDOH needs within pediatric primary care because of the impact that it has and to kind of be more holistic with healthcare. But the issue that came up that the group found was that while it is an important factor, there were limited system-wide programs in pediatric settings that were actually addressing this. So that's where the first step was to do this program development and planning. So that included first doing a literature review just to see what was currently out there, summarize the information, what was high priority SDOH domains that we should be screening for, and then what are the validated measures that we can use. So after that included having stakeholder meetings to kind of summarize what the literature found, as well as finalizing those SDOH domains that should be included. And along with the literature, there was also looking at, because the screening program was going to be embedded within EPIC, it was important to see what was available in EPIC in order to address these needs. And then finally, it was connecting with the EPIC team and integrating it into the screener and the referral into the EMR, and then developing the workflow. So after that meeting, the 6 domains that were selected were health literacy, transportation issues, food insecurity, housing instability, financial strain, and legal concerns. And our overall screening across, these are the core components. So first, what will happen is the patient or caregiver will complete the screening either prior to or during the visit. If there's a positive screen on any of these 6 domains, and that'll result in the provider, or should result in the provider discussing with the caregiver regarding the fact that they flagged positive and if they want any resources or if they want a consultation with a community health worker or social worker. Of course, if there was no need flagged, then they just complete the appointment as usual. So in order to get this rolling, we first piloted it within one clinic, actually in the medical center, on August 22nd, 2022, during patients' routine well-child checks. These were children aged 0 to 18 years of age. And we used the REAM framework to kind of evaluate the program to see what we needed to adapt. So using strategies that we found successful during our pilot, we expanded it out to the 8 community-based clinics at UT Physicians about a year after. So the core components were kept the same, but then it was adapted based on clinic resources, clinic workflows, and processes. And in order to do this evaluation, we used a lot of data from the EMR. We tabulated screening and referral rates, as well as some surveys with clinic staff. So some key implementation strategies that we found helpful during the pilot phase were identifying clinic champions, conducting trainings with the clinic staff, promoting adaptability for screening methods, having monitoring quality and providing education boosters if needed, and then monthly sharing of screening and referral rates. So this wonderful chart here looks a little cluttered, but it shows our screening rates in these 8 community-based clinics. And at the top, you're seeing higher rates among those 4 clinics that actually received the training. So the program, since it was embedded within EPIC, was available to all clinics, but not all clinics had the same, not all clinics had the resources to have a training, or they didn't have a clinic champion because of different reasons. And so during the maintenance phase, you're kind of seeing how a lot of these clinics that had these trainings had higher rates of screening. So from January to September 2024, which was our maintenance phase, across all clinics, about 67% of patients actually received the screening. And with these families, there was about 25% that are actually reporting a need on one or more domains. So that's the patient and their family, which is a little higher than what Dr. Lee was talking about with her when she was looking more at the general population. So that kind of highlights how with these families that have kids, it's a need that we need to be addressing. And then about 55% receive that care coordination or like receive referral for resources or the community health worker. And then this table is, I think, really critical because it shows the implementation and how it was adapted across the different clinics. So if you see the first column, which after the list of the clinics, it shows the number of SDOH domains that was screened in each clinic. And some clinics had fewer SDOH domains. And the main reason for that was because they might not have had the resources or the capabilities to address it. One big thing was the legal issues. So some clinics opted out of screening for legal issues because they didn't have a case manager or a social worker who could actually address it. So they didn't feel like it was appropriate to screen for that. When it came to methods of screening, there were 4 different ways that the patient could get screened. One was through MyChart, the patient portal. The other was in clinic with, it's called captive mode, where they can, they get basically the patient has access to the screen and they get locked out of everything else and they can complete it on their own. And then, or the caregiver. And then the other is with the MA, the medical assistant or the registered nurse. And then the last one is the physician. And as you see, like across all clinics, it is different depending on which mode they used in order to conduct the screening. And again, when it came to addressing the needs, there were multiple ways to address it. One was through printed resources, and then the other was with a referral to a community health worker or social worker in the clinic. And then finally, it could have been a phone call follow-up with the social worker, community health worker. The good thing was that the clinic staff didn't reported that there was an additional time burden too much when they were doing this screening and addressing. So that was good for continuing and maintaining the program. So some conclusions from our training, from our screening, was that we did see that it, for the most part, was implemented at high rates, especially with the clinics that did have the training. And that we have seen that these screening rates have been maintained over time. And what was really important was the implementing the core components while also being able to adapt based on clinic resources and processes and workflows. And our next steps going forward is, one, to address the barriers for the clinics that had the lower screening rates, and also doing some ongoing quality improvement and to try to really understand these lower rates of care coordination and making sure that these kids and their families are getting the care coordination and the resources that they need in order to address their needs. And this is the whole team of people. I am just one person on a very low totem pole. But the core project team is in blue there, and then everyone else is across the whole UTHealth system has been there. And then, of course, this has been funded by the Episcopal Health Foundation. Yeah, and that's our contact information if anyone has questions. Thank you.